maybe we will come to another scenario. A primary gravid at 28 years. She had a cesarean section in the evening. Next day morning, when she went to the bathroom, and while returning, she collapsed following an acute breathlessness. Dr. Sathy, would you like to highlight the probable diagnosis and management of this particular case? Dr. Sathy, you are in.
Yeah. Sir, am I audible?
Yes. Go ahead.
First of all, I would like to quickly express my gratitude towards Kunjimoyedin sir, Dr. Mumtaz, Rajashekaran sir, and Dr. Lakshmi Ammal for giving me this opportunity. Now, coming back to the scenario that has been given to me, this case scenario is highly suggestive of pulmonary embolism. This lady had a massive pulmonary embolism. So, as per now my fellow panelist, Dr. Premila, has clearly explained how to resuscitate a collapsed patient. That goes in here also because she has collapsed. And the maternal resuscitation is the first and foremost, and that diagnosis and management should go hand in hand. So once the patient has collapsed, we should resuscitate and we should call for help, and she should be managed by a rapid response team, and then we should call in the experts also, the cardiologist and also the intensivist. Yes. Then we should arrange for an emergency ECG and echocardiography. In the case of massive pulmonary embolism, there will be a finding. As in the case of this case, there will be some finding, but sometimes echo may not reveal. But in this case, hopefully there will be some finding. And by that time we arrange all these things, we can give safely intravenous heparin. Intravenous heparin in the loading dose of 80 units per kg, followed by 18 units per kg per hour infusion. And by that time, we have got this echo done and the diagnosis has been confirmed. The thrombolysis is life-saving. Thrombolysis, the drug used traditionally used is streptokinase. But streptokinase infusion has a problem of hemorrhage, especially in post-operative patient. So the newer drugs, that recombinant that tissue plasminogen activator, that alteplase, tenecteplase, those have got site-specific action on the embolus and causes lysis of the clots, and so that is life-saving. And we can continue with this intravenous heparin. And in massive embolism that is not responding to this, if it's very huge, then even if there is facilities, we can try emergency embolectomy. That is either by percutaneous method, lysing the clots manually, mechanically, and also injecting that lysins into the locally, and also surgically, thoracotomy. So these are the immediate measures that can be life-saving in the case of massive pulmonary embolism. So once the patient gets settled and then we can change over this unfractionated heparin to low molecular weight heparin, and low molecular weight heparin has to be continued in therapeutic doses for a total of 3 months. And by that time, sometimes in some cases, we may have to continue this for a longer time also. Then in such a case, we can try warfarin. And in such a lady, she may develop post-thrombotic syndrome, as she may have DVT in one of the legs and the lower limb. So she will be benefited with this stockings, elastic stockings, for at least 2 years. So that is the management of this case.
So you'll have to consider thromboprophylaxis also.
Yes, sir. We don't know whether this lady had received any measures like thromboprophylaxis. She had high-risk factors like BMI of 30. Then she had a prolonged labor, and then she had a emergency cesarean section done. So she had 3 additional risk factors. So thromboprophylaxis by heparin could have been given to prevent, because it's easy to prevent, but once pulmonary embolism occurs, it's highly fatal. So we have to do risk assessment in both in the antenatal and the postnatal, post-cesarean phase. And the risk factors, common risk factors, are age more than 35 years, then obesity, BMI more than 30, and morbid obesity that is more than 40 is a high risk factor. Then presence of pneumonia, preeclampsia, multiple pregnancy. These are the high risk factors, and we have to do risk assessment and give thromboprophylaxis. I would like to, this thromboprophylaxis doesn't mean that it's only heparin. We should not forget that adequate hydration, early ambulation, the stockings, these are all thromboprophylaxis in addition to heparin.
Okay.
Okay. Audio.
Yeah, there is some problem.
Yes.
Okay.
So these
Yeah,
are
yeah.
the points. The other
Yeah.
points, that hydration, ambulation, and then
All
timing.
those. Okay.
It's not the timing of enoxaparin is also important. That is, we should not delay heparin to next day. Actually,
Okay.
you can give prophylaxis after 6 to 8 hours of surgery when the immediate
Okay.
problems of bleeding is settled. That then only it will be very useful. Not should not
Okay.
delay for later. Then about dosage, we have to be beware of that. As usual, the blanket dosage of 40 milligram of enoxaparin will not do the work, because in obese ladies, especially when the weight is more than 90, we may need an enoxaparin dose of like 60 for as a prophylactic dose. So we have to
Okay.
modify the dose according to the body weight.
Body weight. Okay. I
Yes.
fully agree with you, Dr. Sadi, in all the points highlighted. Thank you for highlighting on this emerging cause of maternal mortality in Kerala and all the developing countries. Okay.
Thank you,
Thank you
sir.
very much. Okay.
Thank you.
We move on to the next question.